First of all, I want to thank you for that kind introduction, but more importantly, for the opportunity to spend some time here with the Pacifica Institute, and more importantly, to learn about the unique culture, and more importantly, about the Turkish heritage. I'll be honest with you, I have a little experience, and anytime I have an opportunity to reach out to different segments of the population or different ethnic groups, I always try to take that opportunity to try to build those relationships, and I try to learn more than I can give to the audience. But what I was asked today is to speak about healthcare and speak about what is going to happen very soon in 2014. And what was mentioned in my bio is, as you know, I'm an optometrist, which means I'm an eye doctor. And I never in a million years thought that I would ever run for public office. The only thing I ever wanted to do was to open my office, go back to the community that I grew up in, wanted to serve in that community and wanted to see patients. But I learned very early on the role that government played and what I could and could not do. And I got very involved in my community, decided to get involved in the political process. And one thing led to another, ran for office, and here I am. But when I ran, in the state of California, we have a very diverse state here. It's an incredible state. There's so many issues that I had to learn very quickly. Everything from education, transportation, water, air quality, prisons, public safety, of course, healthcare. I always felt I was kind of an expert in healthcare because I treat patients, I see patients. So I had to learn all of those various issues very, very quickly. Local government, redevelopment. So it was a very quick study, but of course, the one issue that has always been very near and dear to my heart, and the reason why I ran, is to provide health care. Well, I really believe that I am in a very unique position because when I got elected to the California State Senate just 2 years ago in 2010, I was very fortunate to be appointed chair of the Senate Health Committee. And what that means is my responsibility is to oversee anything to do with health care in the state of California. Well, that is incredible and that's awesome, and it's very honored that I was able to do that. But the reason why I say I'm in the absolute best time and place in history, because very soon we're going to implement what is called the Affordable Care Act. And I like to spend some time on that because that is going to affect everyone in this country and in this state, every ethnic background, every community, every ethnicity, everyone in the state of California. As you know, the law that was signed into effect in 2008 by President Barack Obama, no, actually it was 2010, I do apologize, in 2000 by President Barack Obama, in my opinion, is the absolute most important piece of healthcare legislation that this country has seen since the mid-60s. The last time that we had such a monumental piece of legislation was the implementation of Medicare and the Medicaid Act during the Johnson administration. Since then, this country has always tried to move forward in healthcare reform. When President Bill Clinton was in office, there's always been attempts at various state levels, at the federal level, but nothing has been able to move forward until President Obama signed it into law. Yes, it has been or had been a very controversial issue, but if you think about this, the United States of America, and California, and every state in the Union, is the only industrialized country in the whole world that doesn't offer some type of universal care for all of its citizens and residents. That is why it is extremely important, because we've always had a patchwork of healthcare in this country. Well, and I want to go back to why I said I'm in the absolute right time and place in history, because I will be right in the center of the implementation of this historic piece of legislation. Let me explain what I mean by that, and then I want to talk to you about some of the problems we're going to have and some of the challenges and what needs to be done to make sure that everyone in this state has access to quality health care. Well, California has always taken a leadership role in every issue, from AB 32, which is, dealing with greenhouse gases, to, environmental issues, to the initiative process we have. As you know, we're always in the forefront. And whatever California leads, the rest of the country seems to follow. Well, we're no different when it comes to healthcare, because California was the first state to implement the exchange. And the exchange is a very integral part of healthcare, because that's where all of us are going to be buying our health insurance for very soon in 2014. California is also moving forward to make sure that we're a state that's going to implement healthcare. There was a very historical moment that just recently occurred, and I'm sure most of you have heard about the challenge of the Affordable Care Act through the Supreme Court. And just recently, not too long ago, the Supreme Court found that it is constitutional, however, with some provisions that it is a tax so that the mandate continue to move forward. But more importantly, the only difference that I think that the Supreme Court made is that it's up to individual states if they choose to participate in the Medicaid expansion. And California, being one of the states that is very far-reaching, I believe will continue to move forward and make sure that all the most neediest population is insured as well. Let me tell you what I think, and the reason why it is so important is, especially in California, I really believe that in this state, and in this country as well, we have a two-tiered healthcare system. We have a healthcare system for the poor, and we have a healthcare system for the very wealthy. But more importantly, if you look at the two types of healthcare systems, the quality that is available to those two communities. If you look at poor communities in this state, these are communities that are predominantly communities of color, African American, Latino communities, communities that people are just barely making minimum wage, or communities that are below or just slightly above poverty level. These individuals, most of these individuals, are on what's called state aid or Medicaid. So there is a higher percentage of people on welfare. The disadvantage is that very few providers or doctors have a tendency to go to those communities, and very few doctors take that type of insurance. Then you have the more affluent communities, where there's a higher percentage of the population on private insurance, and there's a higher incidence. In other words, there's more doctors per patient in those communities. Okay? So here's the problem that we have. We have a disparity in our healthcare system because there is a great need in those poor communities, because it is those communities that have the highest incidences of chronic disease, high blood pressure, diabetes, where they have the greatest need. Well, the way the exchange is going to work, and hopefully the way it's going to make a lot of these changes, is it's going to change the eligibility now for the Medicaid. It's going to increase that. We're going to see higher reimbursement rates to doctors, so hopefully you're going to see more doctors taking that. But what's going to happen now is, because everyone is going to be required to purchase health insurance, anyone which is below 133% of poverty level will be covered at no charge. But from 133 up to 400% of poverty level, when you purchase health insurance, you will get subsidies from the federal government. So in other words, if you make less money, you will get more money back to help pay for it. And obviously, if you make more money, you will get less money. And then anyone above 400% of poverty level, so in other words, anyone who makes more than $80,000 or $85,000 a year will have to purchase it on their own. And also, if you're employed by somebody with more than 50 employees, you will be covered by health insurance through your employer. If you're a small business and you have less than 50 employees, you won't be mandated to purchase health insurance. But if you're outside of those areas, you will be purchasing it through the exchange. Now let me tell you the big difference and why it's really important, and what is going to make this work is the mandate. the mandate is going to be requiring everyone to have health insurance. Now, the reason why that's important is because right now, the way the system is set up, without a mandate, with anyone who gets health insurance, if you work or if you have a small company, if you are buying it through what's called the individual market, where you're just buying it on your own, you don't have much buying power because you're buying from a very small pool, and therefore health insurance is very expensive for you. Whereas large groups like large corporations, CalPERS, where you have thousands of employees or thousands of individuals, they can spread the risk and they can reduce their cost in healthcare. Well, what the exchange is going to do, everyone's going to be in the exchange. And by having more individuals in the exchange, healthy as well as those that are sick, it spreads the risk and it's going to reduce the overall cost of healthcare. Because right now, how does it work right now? Let's say you have a pre-existing condition. Let's say you have asthma and you're self-employed and you want to buy health insurance. So you call up your broker and you tell them, and they take a health history, and they say, do you have any conditions? Yes, I have asthma. Oh, we can't insure you. Or if they do, it costs you a lot of money. It's very, very expensive. So most people who can't afford it, they just don't buy it. Let's say you have diabetes. Same thing. That's a pre-existing condition. You sign up, you're by yourself, you can't buy it through a large company. So what happens? They don't buy it. Here's what usually happens in those cases. Those individuals, when they get very, very sick, very ill, what do they end up using? The emergency rooms. They go to the emergency rooms when they get to the point where they have a diabetic attack, diabetic coma, a heart attack, stroke, because they can't afford the care up front. Going to the emergency room is the absolute most expensive form of care that we have in this country. Now, let's say you are self-employed, or let's say you're making $30,000, $40,000 a year, you got a job, minimum wage, you can't afford health insurance. You end up going to the emergency room, you get a $100,000 bill for health care. What usually happens? They can't afford it, they file bankruptcy, whatever. What this new law is going to do, it's going to protect individuals like that who traditionally have not been able to afford health care, because everyone's going to be required to purchase. The risk is going to be spread out. Now, here are some of the things that are going to happen with the new law, and I have some bills that are literally sitting on the governor's desk right now which will implement all of this as we speak, once 2014 occurs. There is now what's going to be called guarantee issue. In other words, you will be guaranteed health insurance and you will not be denied if you have a pre-existing condition. There will be what's called community rating. So let's say you have diabetes. You are not going to be charged more because you have a pre-existing condition. Everything will be averaged out from the community you live in. Your children. You now will be able to insure your children under your plan until the age of 26. That's huge. How many of you have children in college or are just barely getting started, and once they pass 21, were not insured, but let's say you had an insurance plan through your work? All the pre-existing conditions are gone. They will not be denying you any health insurance. The other things too, there will be what are called, and this is another bill that I have sitting literally on the governor's desk waiting for a signature, is what are called the essential health benefits. This is what we call the floor. In other words, when you get a plan that you purchase or through your work, it's guaranteed that you will get these minimal services. Absolute. Now you can buy a better plan or a higher plan with more, but these are the absolute minimum services. There won't be any more junk insurance. So in other words, you won't be sold a product that seems like it's gonna cover what you need, but won't. Here are the absolute minimum services that you're gonna get. There's 10 of them, and I might forget them, but I'm gonna try to go through all 10. Hospitalization, prescription drug, mental health, preventative care, pregnancy, vision for children up until age 21, I think, dental for children up to age 21. I got 3 more left. I'm getting close. So anyway, but there's 10. But there's 10 guaranteed benefits that you're going to be able to get once you purchase the basic minimum. There's another bill that I will be working on in the special session, because when we get back in January, we're going to have what's called a special session to implement, because 2014 is literally a year away. The exchange in the state of California right now is starting to set up and get contracts with all the various health plans like Blue Cross, Blue Shield, HealthNet, Aetna, to make sure that they get the best deal for everyone who's going to be signing up for it. I'm going to be running some legislation which is called the Basic Health Plan, which is going to be drawing down federal dollars to make sure that we can get the working poor a much better product at a much lower out-of-pocket cost, and we've done some modeling that it will cost as low as $30 a month for somebody between 133 and 200% of poverty level. This is somebody who makes between $16,000 or $18,000 a year to $24,000 to $26,000 a year. They will get a great quality health plan for about $30 a month. So all of these things that are going to occur now and are going to occur and go into effect in 2014 are going to be incredible benefits to everyone in this country and everyone in the state of California. Saying that though, we still have a lot of work to do, and we have some big problems that need to be addressed. And I want to now move on to the challenges that we're going to have in the state. But not only in the state and in this country. And I tell this to every group that I speak to. Let's say we wake up tomorrow and everyone is given a health insurance card with low deductible, low cost, you're guaranteed no matter what. That is only half the problem. That's only going to solve half the problem. The other problem that we need to solve is there are not enough primary care providers in the state to be able to address the need of this huge influx of patients that we're going to be seeing literally tomorrow. That, compounded with the fact that the baby boomers are very soon going to be getting close to retirement age, are going to be needing more health care. We are going to be hit with a huge workforce problem and capacity problem. Now, what needs to be done? There's a variety of issues and a variety of questions and a variety of answers. The first, I think we need to do a multiple track. First thing, obviously, is simple and is making sure that we encourage more individuals going as early back as grammar school to high school to take more math, science, go into the health professions, go into medical school, become primary care doctors, and go back to the communities they came from. First thing. Second thing is to make sure that we build more medical schools, more schools that will provide. Now, I know a lot of you are this is one of the tracks that we need to look at. But saying that, is that going to happen? And if that happens, when are those individuals going to be ready to see patients? 12 to 15 to 20 years. And is not going to address the immediate problem that we're going to have in a year and a half. Okay? But we still need to think about that. And let me tell you the reason why I think that, even that's going to be very difficult. Right now, under the state of California, the California State Legislature oversees 3 systems of higher education. The community college system, the UC system, and the CSU system. Well, we have not built a medical school in the UC system for decades. We have one that we're trying to build right now. It's in Riverside. UC Riverside has been trying to build a medical school for, I'm thinking, maybe close to a decade. But as you know, with the tough economic times and the budget situation we're in right now, it's not happening. So you're probably asking yourself, okay, yes, we need to think about this strategically for the long term, but what are we going to do in the meantime? Well, there is a method, and there is a way that we need to address this. What we need to do is we need to look at all of the providers that we have now currently, which are licensed under the Department of, not Managed Care, Department, I'm drawing a blank, all the licensings of all the professions. What's that?
Medical board?
Not the medical board. All, okay, we have the medical board, the dental board, the optometry board, the podiatry board, Department of Consumer Affairs, that's one. So we have all the health professions that are licensed under the Department of Consumer Affairs, and we need to utilize them a lot more efficiently. Okay? Let me tell you what I mean by that. We have been doing some committee hearings over the last 2 years in the Senate, last 3 years in the Assembly, and we've been looking at workforce. Okay? And I want to talk to you about physician manpower, how we are staffing them, and what we need to do to address these problems. We found out that there is a huge distribution problem. And what I mean by distribution problem is physicians, allopathic physicians, which means medical doctors, have a tendency to, number one, emphasize specialty care. And the reason why they go into specialty care, because they get reimbursed, they make a lot of money. Okay? But number two, allopathically trained physicians have a tendency to go to more affluent communities and larger cities. So we have a distribution problem in the inner city and rural. And we can statistically show that throughout the whole state of California. But what's interesting is osteopaths, which are physicians that are trained more in holistic methods, have a tendency to go into primary care, and there's a better distribution. But what's even more interesting is allopathic physicians, in other words, medical doctors, there is a great distribution. Guess what segment is? It's foreign-born. So what we have to do, foreign-born from another country, well, they will go to a different community and there'll be more primary care. So what we have to do is we need to put emphasis on making sure we get physicians to go to those communities by setting up residency programs there, loan debt repayment, encouraging them to go to the communities where the need is the greatest. So that's a method, a mechanism. But here's another way we can use some immediately impact on the ability for us to have entry point for patients, utilizing the current workforce we have. And there's a couple of professions we can very easily use this. I'm going to name 3 of them, for example, that are so underutilized. Pharmacists, nurse practitioners, and physician assistants. Okay? I'm going to give you an example of pharmacy and what we should do. But it's a very difficult political discussion because traditionally the physician would like to control who does what. Let's talk about pharmacy as a profession. Pharmacy has their educational requirements and what they do has changed dramatically over the decades. Pharmacists that are graduating from pharmacy school now are graduating with 4 years of an undergrad, a bachelor's degree, and 4 years of a doctorate program. Very similar to a medical doctor. Pharmacists are now graduating and they're actually doing residency programs beyond their 4-year postgraduate work. Pharmacists are now doing patient interaction. There are 40,000 pharmacists in the state of California that are better distributed than most providers are, and they're in every segment of the population. We need to look at getting the pharmacist to be a pharmacist provider, not necessarily like a physician, but use them for entry point, where let's say they test for diabetes, high blood pressure, give routine vaccinations, body mass index. So by having them as part of the entry point, they can see these patients at this level, perhaps not the ability to diagnose, but then get them to see those patients, and then if they determine something is, let's say they're diabetic, high blood pressure, then get them into a medical home and utilize the system a lot more efficiently. The second profession are nurse practitioners. California is the only state in the United States that doesn't let nurse practitioners have direct access. Whereas at a national level, nurse practitioners can see patients directly without getting a referral from a physician. Nurse practitioners are also a lot more utilized and are a lot more evenly distributed. So we need to look at the current workforce we have and utilize it much, much more efficiently until that dual track, and we continue to get more individuals to go into medical school, build more medical schools, but more importantly, get more physicians to emphasize in primary care. Yes, we need specialists, but we need more primary care providers to be able to see the influx of individuals that are going to be needing the care very soon. Because to me, if we're going to be requiring every single person in this country to buy health insurance, then they have a right to see a provider. And until we get that workforce segment worked out, we really need to address that as well. So to me, that's the challenge that we're going to have. So we have some really, really exciting times ahead of us, and I feel really excited to be in the position that I'm in, because hopefully the time that I have left in the state Senate, it'll allow me to work on these issues. So we've got some legislation pending in front of the governor's office to address basic health plan, the market reform, what it is that individuals or residents are going to be provided with, the essential health benefit. We've got future legislation, and like I said, in the basic health plan coming up in the special session. Next year, we're going to start working on workforce issues like scope of practice for the nurse practitioners, the physician assistants, the pharmacists, to make sure that we have the capacity here to treat these patients. So those are the things that are kind of exciting and new here in the great state of California. And 2014, it's here. It's here, and it's going to happen. So we're at the end of 2012. So a year from this coming January, every single person in the state is going to be required to have health insurance. So we're doing our due diligence in the state of California. I'm committed to making that happen. I work very closely with the governor, the Secretary of Health and Human Services, Diana Dooley, and we will continue to move forward and make sure that California takes a leadership role in that. So with that, I'd like to thank you for allowing me the opportunity to speak to you a little bit about healthcare.